In this case, you wouldn't have to order more molecular testing because you know there's a KRAS mutation. Generally speaking, we also test for NRAS, but KRAS and NRAS mutations are rarely coexistent. Once you have a mutation in the pathway, there really is an additional selection pressure to have a second mutation. So it would be sufficient once you detect that KRAS mutation to proceed. And we knew that this patient was microsatellite stable. That's really the other key test. It's important also to know BRAF status, but again, KRAS and BRAF, they're similar pathways, and so it's very rare that you have mutations in both of those. Getting a more complete molecular testing can also be important in some cases. It's just that it's a minority of cases, but most specialized centers nowadays are getting full mutational profiling to see if there are other things that might be targetable down the line, usually in later lines of therapy, but something that might be targetable often on a clinical trial with one of the tyrosine kinase inhibitors or one of the other pathway inhibitors, and also for clinical trial eligibility. So at this point in time, you have enough information to start treatment. You don't need to wait. But while the patient is on first-line treatment, which generally lasts 10 months is the average for progression-free survival, we'll often go ahead and get additional testing. FOLFOX and bevacizumab is a very common regimen to use in this situation. Many people would also substitute capecitabine for the infusional 5-FU, so instead of FOLFOX, it would be Capox. And it's often used because there's no hair loss, less diarrhea. Of course, you do have to watch out for neuropathy. And so from a cytotoxic backbone, that is FOLFOX or FOLFIRI, many people will choose FOLFOX on that basis. The people who are strong advocates of FOLFIRI would argue that, that you don't have a cumulative side effect like neuropathy that gets worse with each time you get it. And so they like to start with an irinotecan-based regimen, and that's fine. Now let's talk about the biologic. So in this case, bevacizumab was chosen. That's a very reasonable first-line regimen. It's on the label, it's on all the guidelines, and is typically very well tolerated. You have to watch out for things like hypertension. There's very rare bleeding and clotting events, but these are quite rare. You have to look out for proteinuria, but again, it's rare that you actually have to adjust the dosages. And you don't have things like rash, which you have with the EGFR inhibitors, which many patients aren't eager to get because you have an acneiform, an acne-like rash over the face, the upper chest, the back, that can really impact quality of life. So for that reason, this is a very common regimen. I'd say it's one of the most common regimens that's chosen in the United States. In Europe, on the other hand, they often tend to favor more the FOLFIRI regimens, in part because of cost. Historically, irinotecan came off patent first, and so it was cheaper. And so many of the countries in Europe would start with an irinotecan-based regimen, and as I said, that's quite reasonable to do. In this case, because it's a KRAS-mutated tumor, even though it's on the left side, we still would not use an EGFR targeting monoclonal antibody in the first-line setting, such as panitumumab or cetuximab, because those have been shown to either have no benefit or potentially cause harm. It's important to talk with the patient about what are their goals of therapy and what sort of tolerance they have for side effects. And you can have very reasonable, intelligent patients who have very different opinions on that. You'll have patients who say, you know, doc, I want the most aggressive chemotherapy regimen you have, even if I'm not that symptomatic, because I just feel more comfortable hitting this cancer hard. I want to make it shrink on scan. And I'm fine with managing side effects. It's really not a big deal. Other patients who are equally smart but maybe have a slightly different value system might say, you know, I really don't want aggressive bunch of different drugs type of chemotherapy. I don't want a lot of side effects if you're not going to cure me. If you're not going to cure me, then this is really palliative therapy, and so why would I tolerate a lot of side effects? And so trying to elicit that from the patient to get a sense of it. Unfortunately, because cancer is so common, it strikes hundreds of thousands of people. Most people know somebody who's had cancer. It could be a family member, it could be a friend. And so people will often come in with fairly strong preconceived notions about it. And of course, chemotherapy is different for different diseases. So I've had patients who had a friend with a leukemia who had to be inpatient for for a bone marrow transplant. You know, that's very intense chemotherapy. And so you really can't extrapolate from that and say that that's the experience that someone's going to have with colorectal cancer. And then finally, I think a big driver from my standpoint to talk with the patient about is what are their symptoms now? If you have a patient who has no symptoms from the cancer, if you think about it, from a quality of life standpoint, you can only go downhill because all chemotherapy has side effects. And if they're feeling fine, then it doesn't make a lot of sense to try to make a CAT scan look pretty. You know, you want your patient to look good and to have a good quality of life and to feel good, but it doesn't make a lot of sense to try to shrink the tumor with 6 different chemo drugs. And so that's also important as well. If patients are having pain, if there's an organ that's about to be cut off by a tumor, such as one in the liver that's going to hit the bile ducts, one that's against the ureter that might hit the kidneys, or it's invading a muscle or a bone that might break, or something where you're kind of worried if this thing grows 10 or 20%, my patient's going to have a big problem. So in those cases, I tend to be more aggressive because I feel like I'm doing a benefit by making it shrink. But there's a lot of patients who it's not going to help them all that much to make the tumor shrink. They want to work full time. You know, financial concerns are often major with cancer patients. All of the co-pays and other issues that come up. They want to keep their job. If they lose their job, they're going to lose their insurance. And these are very real concerns that people have. And so I tend to, for patients who aren't symptomatic, to try to get away with as little as I can to try to preserve that quality of life so that we both know I'm not going to cure them in at least the time they have, which hopefully will be a long time, but at least that time is of the best quality that I can make it.